All right, so we're going to talk about pneumonia today and continue on our respiratory disorders. There's the good old Tin Nolly reference that nobody's probably opened, which is fine. The only guy opened it, and I thought either. But for our fellowship, we had to use it. All right, so here's our usual objectives. We're going to define pneumonia, talk about some pathophys. We'll look at our evaluation, and then diagnosis, treatment. Hello, working now? All right, here now. Let's see if we can. All right, is that? No.
You were good at it.
How about now? Yeah? Okay. All right, so we're going to get rolling here, but first we'll do some check on learning. So, covering our asthma lecture yesterday. So you got a 17-year-old female, presents with AD for dyspnea and wheezing, has a past medical history of asthma, has tried her albuterol 4 times prior to arrival, no improvement, vital signs 98/66, heart rate 122, respirators 28, 98 temp, SpO2 88%. On room air, which of the following would prompt a provider to consider intubation? What are we thinking? What makes the most sense? You got, yeah, I would, so what are we thinking? B? Is that what we're agreeing on? Yeah, it's B, right? So, you know, when we're looking at questions, like the first thing I'd recommend is, you know, you can read the question however you want. Some people like to read the, you know, what they're asking. When you're looking at like PANS questions, and like when I did my PAN rate, dude, the questions are like 2 pages long. So once I did that, I started scrolling to the bottom to read what they're asking me first, because there's too much information. This one's pretty easy, but so look at, is the patient stable or unstable in the question? And that can help kind of guide your management. What do we think on this? So look at the vital signs. Do we think stable or unstable?
Unstable.
Yeah, it's unstable, right? So something's going on. Especially with those vitals, like heart rate 122, tachypneic at 28, and then 88%. I would not expect that patient to just be like, I'm going to take a nap real quick. You know, they're sick. So you start to see drowsiness. That's portends a bad outcome where they're tiring out, and we need to do something about it. So that, in that case, you know, likely consider intubation in this patient. All right, we got another one. You got a 19-year-old female, presents with AD dyspnea and wheezing. She can only speak 2 or 3-word sentences and report similar episodes over the past few months. Denies any medical problems or medication use. Vital signs 120/86, heart rate 90, respirators 30, 98.7 temp, SpO2 96 on room air. Lung exam reveals diffuse expiratory wheezing. Cardiovascular exam, regular aphorism, no murmurs, rubs, gallops. Based on the most likely diagnosis, what is the most appropriate initial treatment? Yeah, it's going to be C, right? We're going to give nebulized, some sort of nebulized, short-acting beta agonist for this patient. Likely we'd give a Duoneb, so it would have ipratropium in it. But, you know, we give albuterol. All right, let's say you give, you know, 2 rounds of the albuterol, patient's improving, and you're going to discharge them home. What do they go home with? Just steroids, right? Bring in steroids. I mean, we want to make sure they have all their other equipment. Like, do they have a nebulizer? Do they have an albuterol inhaler? Do they know how to use it? It's important, but they need to get steroids before they go home, or when they go home, I should say. All right, we got one more. So, 23-year-old male brought in by EMS with shortness of breath and expiratory wheezing. He has received 3 back-to-back Duonebs by continuous nebulizer. The patient appears exhausted, demonstrates sensory muscle use. Vital signs 105/56, heart rate 132, SpO2 86%, respirators 32. Which treatment is indicated for the patient at this time? So of those options, what are we thinking? you say?
Steve?
See? Yeah, epinephrine. So of those options, epinephrine. Likely we would start magnesium first, and then consider epinephrine in this patient, but that wasn't an option on there. We didn't talk about Heliox, so it's not Heliox. Atropine, that's, we're not using that. That would be like if they were, in a bradycardic arrhythmia or something. And then the other ones aren't really indicated. Like montelukast is more for chronic outpatient management if they have some sort of allergy component to their asthma. And then antibiotics likely aren't indicated in this patient either unless you were concerned for a pneumonia, which coincidentally is what we're going to talk about right now. All right, so here's our warm-up case. She got a 17-year-old female brought in to the ED by her husband for fever, cough, blood pressure 96 over 80, heart rate 104, rest was 24, 101.1 temp, 92%, SpO2. Physical exam, she appears ill and diaphoretic, history of diabetes and heart failure. Based on the most likely diagnosis, what is the initial treatment? So, what do we see in the vital signs in this patient? Like stable, unstable. Yeah, so you guys remember did you guys have surge criteria in your first test, I think? So does that, you got surge, you meet the surge criteria there. So this patient is likely septic, blood pressure is kind of soft, still not hypotensive, but given the history and the age of the patient, we're going to call this sepsis. So this would be like, obviously our ABCs, IVO2 monitors, we get blood cultures, and then for this one we'll talk about the treatments and how we kind of categorize them for pneumonia, because there's different treatment options, whether they're outpatient, inpatient, healthy versus comorbidities versus sepsis or ICU players, and we'll dive into that. And then there's our approach to the critical patient, like I just talked about. So ABCs, we do have that non-invasive positive pressure ventilation, which is always a consideration. When we talk about ARSNet, that's something we utilize when we're putting a patient on a ventilator and we're adjusting their tidal volume. So what we noticed is using lower tidal volumes is more helpful because we avoid the risk of like pneumothorax or causing some sort of iatrogenic injury. So we use a little bit lower tidal volumes. And then when we talk about predicted weight, it's not something we're testing on, but you'll see it definitely in phase 2. We use ideal body weight for these patients, so it doesn't matter if you're 6 foot and 400 pounds. Your ideal body weight is based on your height, so your lungs aren't going to be any larger. If you're 400 pounds versus 200 pounds, it's going off your height. When we are using the ventilators, we use that ideal body weight or predicted body weight is another name for it. All right, so here's some terminology. So we have community-acquired pneumonia, which is, some sort of acute pulmonary infection in a non-hospitalized patient, or a patient residing in a long-term care facility, like we call it like a SNF or whatever facility they're in. So for 14 days before presentation. We have hospital acquired, so that's anybody with a new infection 48 hours into their hospital visit. Then we got ventilator associated, so that's anything over 48 hours after intubation. We used to call it healthcare associated pneumonia, which we don't call it anymore. It's an outdated term. I mean, some people might still call it that, but it's technically not standard anymore. But let's talk about some pathophys for pneumonia. So you have really some sort of microaspiration bacteria gets into those lungs. It can be from the GI tract, it can be from the respiratory tract down the trachea, it can be from inhalation or contagion from somewhere else. And most commonly, it's going to be our strep pneumo. You can also get hematogenous spreading with staph and strep, so that's a consideration as well. But we also want to look at like predispositions for pneumonia. That's usually anybody with an aspiration risk, so like the elderly patients, our alcoholics, or we'll talk about some of the other pathology or pathophysically might see patients at more increased risk for pneumonia in the lecture. All right, so that bacteria gets in the lungs, it creates an inflammatory response. It tends to cause that productive cough, so they'll have some sort of sputum production. Everybody will describe it in different colors. The colors don't really mean or they don't equal anything. So a certain color doesn't mean it's this bacteria versus that bacteria. Usually they'll have some sort of speed of production. Patients describe it in so many different ways. It's kind of hard to quantify it or qualify it, say, with their based on their symptoms and what their sputum production is. But then we have atypical organisms, which are a little bit milder of a response. They may not be febrile, and they'll likely have like a non-productive cough. And then most of the patients, it says half the patients, no specific pathogens identified, like more than half the patients, because we don't actually run sputum samples on everybody, so we don't know what's actually causing it. What we do is treat them empirically based on the categories we'll talk about here and what we think the most likely bacteria that's involved. So strep pneumo is going to be our most common cause across the board, adults, children, everybody, even in like immunocompromised and everybody else. Strep pneumo is still the most common. There are some atypicals that we like to think about, and a lot of our coverage includes the atypicals nowadays. We used to just treat patients with monotherapy or a single antibiotic, but that's fallen out of favor now, just because of resistance and the different bacteria we might see with it. So we usually cover for most of those on there. What's important, and we'll show the different ones later in the lecture, especially for board questions. Those atypicals will have certain findings associated with them that you'll probably never see in real life. Other than Legionella, you'll see like some lab derangements, but the other ones like bullous myringitis, and we'll cover them. We have like a little spreadsheet to kind of help you differentiate. They're common board questions, not as helpful in real life. And then we always want to think about those immunocompromised patients as well. But even with the immunocompromised, it's usually still the commons being common. It's going to be strep pneumo, followed by some of the other ones that we'll dive into, like our colon jelly sputum and Klebsiella and things like that. But what do they present with? Cough, fatigue, fever, dyspnea, usually complain of sputum production depending on what the bacteria is or whether it's atypical or typical. And then some will report like a pleuritic chest pain as well. These symptoms are highly variable, so you're not going to see it in everybody. You'll also see some of these symptoms with just a URI or a bronchitis. This flu season has been really bad, so we see sometimes it can be hard to differentiate whether it's flu versus pneumonia. So in those instances, we may treat them for pneumonia as well as the flu. And we'll talk about what complication, which viruses are associated with pneumonia in certain patient populations here. They'll complain of weight loss, myalgia, fatigue, maybe dizziness, weakness. And then the atypical pathogens like your Legionellas will present with GI symptoms, so you might get like nausea, vomiting, diarrhea, and some belly pain. You can also get neuro symptoms with it as well, so you'll have a headache with your Legionella. And then you can get extrapulmonary symptoms, joint pain, hematuria, skin rashes. Not as common, but it is possible. All right, who's at the highest risk? And this is kind of how we stratify some of our treatment. We look at the risk because we don't know what the bug is, so we look at some risk factors and we kind of stratify them into whether we think they're the highest risk, the lower risk, whether we can treat them as outpatient. But like everything else, I feel like the really young and the really old are always an at-risk population. And then we look at certain minorities and immunocompromising conditions place them at higher risk, but especially like patients who can't mount the same immune response, like your asplenic patients, transplant patients, your HIV and sickle cell. We tend to treat them a little bit differently when they present. But for like your strep pneumo, your classic presentation is on there. So you get that sudden onset disease, you get the rigors, bloody sputum, high fever, chest pain, and then you have some sort of lobar pneumonia on your imaging for these patients. All right. So in these patients, labs can be helpful, but as we hopefully you guys learn pulmonology, pneumonia is a clinical diagnosis, so you don't need labs and imaging on it. Now they can help you, especially if you're trying to determine maybe how sick this patient is, but most of the time if you get like a CBC and a CMP, you'll see a leukocytosis. You may see those elevated, like if you were to get a liver panel or your comprehensive metabolic panel has liver enzymes on it. You might see that elevated bili and hepatic enzymes and hyponatremia. That's typically with like Legionella specifically, but it is a consideration if you're unsure or if they have the right history where you would suspect that. But our labs can be helpful. Most commonly, you'll just see a mild to moderate leukocytosis in these patients, but none of them guarantees you a pneumonia. So you have to look at the whole patient, history, presentation, and then we'll use a chest x-ray to help us on this. Most of them can be treated with antibiotics. We like to use a beta-lactam. And it says macrolide on there, which has fallen out of favor because we gave Z-Paks forever and we have some resistance to it. So a lot of times we'll use a beta-lactam and like doxycycline nowadays, which doxy's great for everything. And we should all just probably take doxy once a year to help out. So, like it says on the bottom, we have that increased resistance. So we tend to change our protocol every once in a while based on resistance. We also can look at our antibiograms at our local facilities and see how high our resistance is. So sometimes you may not have a very high resistance to your macrolide and it's reasonable to prescribe it. The only reason I like it is because the Z-Pak's easy, it's 5 days, and it's a lot better compliance versus looking at like your doxy or your fluoroquinolones, and there's usually less side effects with it as well. Your azithromycin also has like anti-inflammatory properties in the lungs, so it's also helpful when you're treating infections too, and for symptomatic treatment. All right, what do we see on here? It kind of says it at the top, but yeah. So everybody sees you have like that fluffiness there, consolidation. You're especially on that right heart border. You're kind of blunting in. You can't see what. I mean, we don't need to know what lobe it's in, but what lobe does it look like? Maybe. Yeah, it could be a lower lobe. It also could be the right middle lobe as well. So it's kind of hard to tell on that image, but this is like your classic X-ray for a lobar pneumonia. All right, so the other ones we worry about are like staph pneumonia. So we need to consider this, anybody immunocompromised, nursing home patients, our cancer patients are at increased risk, or anybody with, that could possibly aspirate it. IV drug users are another consideration. But for board questions, the thing we talk about it the most is it's associated with like the flu or a viral illness. So when you're taking a test, you're reading questions. They had, diagnosed with the flu, or they had a viral illness for the last week. You want to think like a staph infection, staph pneumonia is associated with it. It's, a more, I don't know if it's insidious onset, but it's a milder onset. So they'll have low-grade fever, speed of production, some shortness of breath. But our chest X-ray will usually look not great. So it won't be your classic lobar pneumonia. You'll have multiple areas infiltrate. You may have an empyema on there. And then we have to consider whether they've been hospitalized recently, had antibiotics in the last month, and then any comorbidities, because we want to cover for MRSA in these patients. All right. So yeah, it looks a little different, right? So you've got, almost that entire lung with consolidation in it. What age patient does this look like?
Adolescent.
Young, right? Pediatric patient. So, the chest X-ray looks a little different. Good. All right. So Klebsiella is one we can, most commonly we call it board questions, Courant jelly sputum, typically in an alcoholic. However, it's anybody that's at risk for aspiration, so elderly patients are at an increased risk. Any like neuromuscular disease, chronic lung disease, we need to consider a Klebsiella pneumonia. And this one, it has a similar presentation, that fever, rigors, but You may have that like belly sputum, which is what we love to ask on questions. What else? There's something else I was going to say on this one. Yeah. All right. Next is Pseudomonas. So this can cause a very severe pneumonia. They might have cyanosis, confusion. It's very hard to tell just based on your presentation and physical exam the difference between most of these pneumonias. And it's really hard in real life too. So a lot of it is just history. If we can ascertain that from the patient. Most patients don't tell you they're alcoholics, so you sometimes have to elicit that from them. But it is important knowing where they live, whether they're in a nursing home facility, and we kind of identify these. This one is typically associated with some sort of hospitalization. So any of those, like if they had any prolonged stay recently, if they've had antibiotics usually in the last 30 days, or anything that can weaken their immune system, and it's associated with usually some sort of healthcare facility, we worry about Pseudomonas. All right, H flu. It's hard to differentiate that as well. That's why when you'll see in our treatment, we cover with usually beta-lactam and other antibiotic, or sometimes broad spectrum. So we cover all of these bugs, with the H flu. Since we immunize for H flu, it's not as common anymore, but we still can be concerned about it in those elderly patients or chronic lung disease, sickle cell, immunocompromised. Really, it's like everything, right? Like every single one of them. It's going to be worse if they have any of those, so we need to consider it. And like it says, the vaccines drop the rate like significantly, so we don't see it as often. But once again, we never actually test the sputum, so we don't really know what's causing a lot of these right now. The chest X-ray looks a little bit different on this one, on that one. So it's just multi-lobar infiltrates, which looks similar to actually just like a viral pneumonia or a viral upper respiratory infection when you get a chest X-ray. So it's a little bit more difficult to differentiate on X-ray. Then we have our atypicals. So these are like your chlamydia, mycoplasma. The issue with these is they don't have a cell wall, so they don't respond to the normal beta-lactam antibiotics. So it says on there macrolide. Now it's more doxy or a respiratory fluoroquinolone. We don't like to jump to a fluoroquinolone just because it's a lot bigger gun and it has a higher side effect profile. So there are certain indications we will, and we'll cover those in here. But typically doxy is going to be our go-to for these atypicals now. And then Legionella. This is a fun one for board questions. It doesn't happen very often. I think maybe once a year you'll see on the news. Like I think last summer it was like some hotel in New York or something like that. It's usually associated with like the air conditioning or the HVAC system and some sort of water leaking in there. So not as common, but it is something to consider, especially if they've had any sort of like recent travel. They have seen it in hospitals in their HVAC systems too, but that's a lot less common nowadays. Smokers are at increased risk, basically for everything, but increased risk for Legionella. There's no seasonality, that's why you see it a lot in the summer. Like I think it was last summer I saw it on the news. And the reason it probably happens during the winter, but we're treating all the other flus and pneumonias and we're not testing for it. So it's possible they had that too, and we're not drawing labs on everybody, so it's, if they're a milder illness, we may never actually diagnose it. I've never diagnosed one, but someday I will. Someday I'll catch it. They'll have the neural and GI symptoms. So abdominal pain, nausea, vomiting, diarrhea is probably the more common symptom you're going to see on there. And then you need to, especially in test question, make sure you're reading the history. If there's any, recent travel, they were staying in a hotel, we want to consider these. And this one has those extra pulmonary symptoms, so it can cause a sinusitis, pancreatitis. So in these ones, like you might see that elevated bilirubin in this patient, you may see a transaminitis. And then the chest X-ray is, it looks almost viral on there. So you don't see those, you don't see that focal consolidation like you would see in a lobar pneumonia. You just see like that diffuse patchy infiltrates throughout the entire chest X-ray, which is why in these cases your labs can be helpful to determine this. because it doesn't look super impressive on there. Then we have our chlamydia pneumonia, usually very mild. These are ones with like sore throat, may or may not have a fever, non-productive cough, maybe have rolls or wrong kind of physical exam, and this one is a unimpressive chest X-ray as well. It looks similar to like Legionella or a viral illness on the chest X-ray. It is linked to adult onset asthma. Then we have our mycoplasma. So this one is like tends to be in clusters every 4 to 8 years. Very mild illness. They may have some retrosternal chest pain. The important thing to remember on this one are the extrapulmonary symptoms. This is a classic board question with that bullous myringitis. So you'll see a bulla on the tympanic membrane. So since we're not covering HE and T, there's a random picture of a tympanic membrane. I don't know what else it could be. And then viruses. So, influenza is the most common viral pneumonia. It's obviously seasonal. It's horrible right now. It's a very bad year for the pneumonia. So we need to consider a viral pneumonia, especially in pregnant patients, so they can get a very severe pneumonia. Most patients or people tolerate, their body, mounts a response and fights off the influenza virus. However, certain patients, it can portend to worse outcomes, especially in pregnant patients. And good old tuberculosis. So we always want to consider that as well, especially in the right history. Anybody who had any recent travel, or they were born overseas, grew up in a different country, you need to ask yourself, like, could this be a tuberculosis? It presents similar to a pneumonia, but we need to look at those risk factors. And these ones have more like those B-type symptoms, like night sweats, weight loss. They may have hemoptysis. So we need to elicit that from their history if we suspect a tuberculosis. And these patients, if we suspect it, then we have to quarantine them. So all of our hospitals and clinics have isolation rooms, so negative pressure rooms, so we can avoid spreading that bacteria because it is extremely contagious. So this is one of the few that if you suspect it, we need to get that sputum sample on these and culture it. Then we have fungal pneumonias, a lot less common, but they do have geographical areas that you might see them in. So, when you see like a spelunker, think histoplasmosis. So some of this is just like classic board question type stuff. I'm sure someday somebody will tell me he's a cave diver, and I'll be like, holy shit. I'll be like, okay, man, gotta be histoplasmosis. It probably won't be, but in those instances, you have like the southeast U.S., really in like your Southern California, and I want to say Arizona, you may see that like blastomycosis. And then you have other ones like aspergillosis and so like psittacosis or Q fever. So just pay attention to history, especially when you're taking board questions if they say some random thing. Like, I've never had a patient, I'm like, what do you do for a living? I'm a bird fancier. Someday. All right, and then once again, we worry about post-viral pneumonia. So anybody with that recent influenza, we want to worry about staph pneumonia. So that's, I know that, I think that was definitely on my pants a long time ago. So just if they had a recent influenza virus and there's pneumonia, I think staph pneumonia in these cases. And that just means we have to change our therapy to cover it with like something like vancomycin. And then there's also like PJP pneumonia, which is associated with our AIDS patients, and that's usually like with a really low CD4 count below 200. However, strep pneumo is still the most common, but you might see these subacute presentations. Chest X-rays, very subtle. You just see the interstitial infiltrates like you would see with a virus, or like you'd see with some of those atypical pneumonias. These patients may have a LDH that's elevated, and we just treat them with a little bit different antibiotics if we think it's that PJP pneumonia. So like the trimethoprim, sulfamethoxazole is a good one. And then we add on there one of those pentamidine or dapsone and some steroids for hypoxic patients in these ones. What's the other name for trimethoprim sulfamethoxazole? You guys remember? Generic Bactrim, Septra, there's like, we call it all kinds of everything. Very common antibiotic. Used to use it all the time, which is probably why it has resistance and it's fallen out of favor. But it is a great antibiotic, especially like if you're a battalion P, you're deploying, because you can use it to treat UTIs, you can use it to treat staph infections or MRSA infections on the skin. So it's a pretty, it's a great medication that you can use in a lot of different instances. So I do like it and I still use it. All right. So key things in the history, big one, any recent antibiotic use, because that's going to change our management of what we're going to, what antibiotics we're going to give the patient. And then we want to look if they had any recent, neurological disorders. So anything that could affect their swallowing function and increase their risk for aspiration, we want to think about, because that will change our management. And then we want to know if they were coming from a nursing home, if they were recently hospitalized. And then how long have they had the symptoms? So a lot of times, most things are viral, but sometimes if they've had viral symptoms, but they might be a mild afebrile on exam, not significant. I usually treat them if it's been 10 days for like a bacterial pneumonia. That's just my practice. We also want to know about any extrapulmonary symptoms, which can kind of help us. It can help us a little bit. So a lot of patients have extrapulmonary symptoms with like nausea, vomiting, diarrhea. But if they do, you then want to think about, could this be like a Legionella or something? A lot of times there will be other sick contacts in the home, so it can kind of help cue you in that it's likely, your community-acquired pneumonia. All right, and there's the classic presentation. I don't feel well. I got a fever. They got some purulent sputum they're coughing up. And then they may have shortness of breath, chest pain. Hemoptysis, you can see that quite frequently, and that's why you get that like blood-tinged sputum that you see very commonly with your strep pneumo. I guess you can call it hemoptysis, but really it's, they're not really coughing up any blood. It's really just kind of tinged in there from how frequently they have to cough. And then, like it says, we want to consider PE. Usually, the PE, we'll talk about it in later lectures. Yeah, it can have a fever with it, but oftentimes it doesn't have a fever. But yeah, you can consider PE. And then your physical exam is important on these patients, so that's why we do a good lung exam, so you can hear, really almost any type of adventitious lung sounds on these patients. What's important is looking for, where you hear that sound. So you might hear it, in one lung field or the, right lower lobe. So that's a consideration. So when you're listening, you hear a difference from each side. That can help kind of cue you in that maybe there's some sort of lobar pneumonia going on. But you might hear bronchi, wheezing, ralls. If there's a proeffusion, then you actually check for dullness. That might be there. And then our radiographic findings are what are going to help guide us as well, especially if it's lobar pneumonia and what we see on there. However, I get a lot of normal chest x-rays because sometimes the pneumonia might not be evident, but you have to kind of suspect it based on your history and exam. So even, that's why it's a clinical diagnosis. A lot of times, the chest x-ray will be benign and I'll still treat them for pneumonia just based on my gestalt. And then we want to consider those typical versus atypicals. Or walking pneumonia is what we used to call it. They'll have fever, tachypnea, tachycardia. Not everybody, but usually with like a strep pneumo, you will have a fever. And like I said, maybe I said no. Children, all of them have a fever with everything. Whether it's a virus, whether it's bacteria, they get like, a 104 fever in a lot of kids. When it's an adult, that's usually more significant. This year, though, with the flu season, like every adult has like 102 fever, which is abnormal. Normally, flu season, like adults aren't mounting that robust of a response. So, but you might have the fever, tachypnea, tachycardia, and then some sort of adventitious lung sounds on your exam. All right, so what do we do for them? So, you know, we can get a chest x-ray on them if we suspect pneumonia, and it can help us in the diagnosis. And it may be more helpful in ruling it out, like if, we've been doing that a lot lately because people show up like the second they have flu because it hits pretty hard, and the test is not 100% sensitive that early, so a lot of times the chest x-ray can help me kind of differentiate, okay, that looks, I don't see pneumonia on there, it seems like it's the flu, but the testing, you know, the flu test is negative. We don't need a CBC and a CMP and a UA in everybody. We get those for our sicker patients typically, or if the diagnosis is in question, we'll add our labs on there. In the right patient population, anybody with like heart disease or elderly, we may add some cardiac markers on there, just because, you know, it could present like acute myocardial infarction could present, you know, with the pneumonia, or it can present, you know, they mistake those symptoms for pneumonia. We don't need a D-dimer in all these patients unless we suspect some sort of pulmonary embolism, or it's on our differential. But what do we do for all these people? We treat them empirically with antibiotics. And we'll cover that shortly. So there's our initial, you know, everybody A, B, C, D. And then we move into our antibiotics. So we treat these empirically. We look at the history, the symptoms, and then we want to look at any risk factors or comorbidities. And then we kind of stratify them into a certain category of which antibiotics we're going to use for these patients. You guys will become very proficient at this, you know, in phase 2 and in your clinical practice, the community acquired pneumonia treatment guidelines. But most of it is going to be based on whether they're outpatient or inpatient for treatment, and whether they're young and healthy or they're older with comorbidities. Then we kind of stratify them in different categories, and then we have our sepsis ICU type category. All right, so this is going to be a little different than what's on your slide. So you may want to write it down for the outpatient. For some reason on the slides, and I fixed it, and then it reverted back on Canvas. So I think these next 2 slides, the outpatients, are going to be a little bit different treatment. So I'll write it down on there. But currently, right now, we can use amoxicillin if they're young, healthy, no comorbidities. And as long as for using Zithro, you want to look at your local antibiogram. But typically, like I like to use amoxicillin and doxycycline. So we're no longer using monotherapy, but we want some sort of beta-lactam, and then we want to add on our additional coverage on there. So that's either azithromycin or doxycycline. And then if you want to do monotherapy, and that's in a, you know, that's not usually in our young healthy population, but some people still give a fluoroquinolone or respiratory fluoroquinolone as well. All right, so our next option. So we got outpatient, young and healthy, and then we have outpatient, adult with comorbidities. Is anybody with like heart disease, any lung disease, liver, renal, diabetes, anybody with malignancy, alcoholic, or concern for any immune compromising conditions, we broaden our coverage. So we still use the amoxicillin, but we add that clavulanate, which is called, the other name is Augment, is the common trade name we call that. And then we add either azithro or doxy to it. You can also use cefpodoxime as well, which is just a cephalosporin that is a great PO option. It's more expensive in the civilian world, but in the military, it's all monopoly money, and we can give them that. And then you can also, consider monotherapy with one of your respiratory fluoroquinolones. I think your guys' slide had like IV medications for all the outpatient, and I was like, that doesn't make sense on there. That's why I changed it. All right. So here's our like fluoroquinolone disclaimer. And, we usually reserve those for any patient that can't tolerate other agents, so maybe they have some allergies.
If they have any pneumococcal resistance, it's documented, which I've never seen that, but I guess it's a thing. Or if they failed any other therapy. So if we've already treated them with our amoxicillin and doxy, still having symptoms, we can move over to that fluoroquinolone. And then like some of the contraindications are like myasthenia gravis. All right, so now we have our inpatient adult with comorbidities. So the same comorbidities that we saw in the previous slides. These ones just use some beta-lactam, or in this case, like a third-gen cephalosporin. And then we are giving it IV. So our most common one is ceftriaxone or Rocephin for inpatient, especially in the ER when they show up. It's a pretty broad gun. So a lot of times we give any septic-like patients, we give them a gram Ancef right when they show up. And then we add on, the azithromycin or doxy for these patients. As well, we can use cefotaxime or ampicillin. You can also still use respiratory fluoroquinolone, and we can give that IV as well. And then we have our inpatients, our septic shock patients, anybody on a ventilator or anybody that's septic and it's a hospital-acquired pneumonia. We broaden our coverage a lot more. So we use one drug from each of these categories. So you guys may, you may want to know these drugs. I know it's a lot of them. You probably don't need to know them all, but there's some very common ones on there that you should probably know. So vancomycin, certainly. So we want an anti-MRSA agent. We don't use linezolid. That's like it's a big gun. It was a lot more popular, like 40 years ago. So we kind of reserve that as last resort, but vancomycin is a very common one we're going to give. And then we want to add an anti-pneumococcal beta-lactam. So one that we use, a pretty big gun in the hospital, is the pip-tazobactam. We also call it Zosyn. Cefepime is another very common one we use. Then you have your Penims on there, which are pretty big guns. And we need to add anti-pseudomonal, so most commonly is going to be your levofloxacin that you're going to see on there. That makes sense. I know it's a lot of drugs. All right. So, what's our disposition? That's always what we're asking in the ER because we're all about productivity. Some facilities, I feel like we don't even care about the patients anymore. It's just like productivity. Because we have, not to go on a tangent, we have like stupid metrics we have to meet depending on their triage category and their illness category. And like some have to be in and out in an hour, some are like 2 hours if you don't do anything. So it's really annoying. It's like, well, sometimes it takes a little bit longer and they ding you on that as a provider. Nothing you guys didn't know, it's just kind of annoying and irritates me sometimes in certain hospitals when they're looking at productivity. And then they send out like mass emails of everybody on their ranking. You're like, oh, it's me. But shame is a very great tool sometimes. So some of the risk stratification we can use, like our Curve 65 score. So this just looks at illness severity, and it gives us our prognosis for 30-day mortality or patients at higher risk. So Curve, we use the letters in that acronym there, and it's confusion, any uremia, so they're elevated BUN. Respiratory rate over 30, and any signs of hypotension, and then if they're over 65. So this is probably our most validated tool. Unfortunately, it requires us to get labs in everybody, and if they're sick enough, like I would say if they had that tachypnea and hypotension, I would definitely, certainly be getting labs and likely blood cultures, and I would categorize them more in a sepsis category. But this one can be a little bit more complicated, and anybody that's got a 2 or higher, we need to admit those patients. But like it says, we don't even have hypoxia in there. It's a very narrow tool, but it is helpful if you're trying to risk stratify who may or may not need to be admitted. All right, so ICU patients. Hopefully it makes sense. The sickest patients go to the ICU. Anybody that's, has a breathing tube, anybody that requires hourly checks, anybody that requires certain medications that require drips, like your diabetic, the DKA patients that require insulin drips. These are patients who go to the ICU. So for these, like septic shocks, likely to go to the ICU. I don't know so much about multilobar infiltrates alone, but in conjunction with sepsis, that might go to the ICU. Any confusion, altered mental status may require more frequent checks. And then, if they have all of those lab arrangements, maybe at once they would go to the ICU, but it'd be a hard sell. And then if we haven't relieved any of that tachypnea with our resuscitation, that might be an ICU player. Any hypotension or hypothermia is likely for us. But, once we start antibiotics, we should see, most patients will see resolution 3 to 5 days. Some will start to see, like maybe they'll be afebrile 24 hours after starting antibiotics. It's all, it's all variable depending on the patient's immune response. Oftentimes we'll give them 2 to 3 days of IV antibiotics and transition them to oral antibiotics and discharge them. If we're discharging them from the ED, we always want to look at those social factors. So do they live at home alone? Do they, maybe they have to travel 3 hours to an ER, or they need scheduled like IV antibiotics. So these are patients that we would likely keep in the hospital versus discharging home. And then we want to consider all our special populations like alcoholics, because they got that higher risk for one of lung diseases, but also aspiration. So we want to consider that. They can be malnourished. Usually they're not eating as appropriately as they should, and they're surviving off beer or whatever. Like, you guys heard like beer potomania? Did you guys cover that before? We're not getting it, but all right. Strep pneumo is the most common, even in alcoholics. We always consider that Klebsiella, Courant jelly, sputum. Luckily, our medications we're prescribing are covering all of those. They just have a higher mortality rate in alcoholics compared with non-alcoholic patients. And we want to consider diabetics as well. So 4 times more likely to have pneumonia influenza. They have a higher mortality rate if they have if they're diagnosed with those. So these are ones we want to consider, sometimes treating prophylactically, even if we don't have evidence of pneumonia, just because they're at a higher risk. And then they have increased frequency of those atypicals and staph aureus pneumonias. So some we want to consider as well. All right, pregnant women. Yeah, like one of the most serious non-obstetric infections. So maternal mortality is 3%, which that's pretty high. Everything we do in medicine, you always see percentages. Like if we're using criteria to rule out things, we like to have them under 1% for everything we do. So this is a little bit elevated, so it is something we need to consider. Really, it's whether it's a viral pneumonia, because that can cause more serious illness in the pregnant patient versus the non-pregnant. So it's something we want to consider. If we think it's a influenza, we want to treat them with Tamiflu or some sort of antiviral in pregnancy, so we can avoid that pneumonia that might be associated with it. So once again, pneumonia kills the really old. So usually the elderly patients have some comorbidity associated with them. Very rare, and I get super suspicious when like a 7-year-old's like no comorbidities. I'm like, either they didn't see any medical care or they're extremely healthy, but usually it's not. Usually they don't look extremely healthy. But we want to consider anybody over 65 and treat them appropriately. So whether it's empirically versus prophylactically, we may not have a slam dunk diagnosis of pneumonia on your chest X-ray or based on your history, but it's something we want to consider in those elderly patients. The elderly present more often with, the non-pulmonary symptoms. So, commonly in the ER we get elderly patients that are altered, and so typically we treat them with a very shotgun blast everything. It's very broad, but I would say the most common that's going to cause that like delirium I think you guys just tested on is going to be a urinary tract infection or a pneumonia in elderly patients. So it is something we always need to consider when they present altered. And they might have confusion, like syncope, falling. We see it very often, especially coming from nursing home facilities when they have a change of mental status in that patient. So something we need to consider. And most elderly patients aren't febrile with these diseases. All right, So here's our quick little check on learning. So 52-year-old male, history of smoking, presents fever, cough, dyspnea for 2 days, exam is done both for tachypnea. Mild bronchi, chest x-ray shows no infiltrate in the right lower lobe, vital signs, heart rate 110, blood pressure 110, 76, respiratory 22, SpO2 95, temp 101.4. So what do we think? Stable? Unstable? Let's say stable, right? That sounds stable. Yeah. So, you know, for our history, obviously we want to know his past medical history, which we have on there. So he's a smoker. We want to know, does he have any comorbidities? Then we want to consider our differential diagnosis here. So really, pneumonia is going to be at the top of our differential here, but we also want to consider other things. But since you have that right lower lobe infiltrate on the chest x-ray, it's, you know, our leading diagnosis is going to be pneumonia. And then physical exam, you know, he's got mild bronchi. We likely get a chest x-ray in this patient. He does have, you know, SIRS criteria, so it is reasonable to get CBC, CMP, lactate, and those labs. However, if the patient is stable, it's one of those things we always, we have to meet sepsis protocols, which is like antibiotics within an hour of the patient arrival. So this patient may or may not get blood cultures. I likely wouldn't draw any blood cultures on this patient, but I would just make sure I mention in my note, like, unlikely sepsis, you know, patient. We have a source, we have an infiltrate, the patient's, you know, 52, only comorbidities, smoking. And then we just make sure we document appropriately. And then treatment for this one, what antibiotics do you think we do for this guy?
One down doxy.
What was that? Yeah, so this patient, he's a smoker. It doesn't list any comorbidities. I would treat him with like augmentin doxy or zithromycin depending on the local antibiogram. But I just use doxy for most people around here based on the antibiogram. Yeah, this patient, you know, as long as I see, like I give him an antipyretic, he's still stable. A lot of times that tachypnea and the tachycardia will be from the fever, so we'll treat that. Maybe not give some fluids. And if I see a response, this patient will likely go home. All right, what questions y'all got? Really? All right. So I'll be back at 9:05. We'll cover. In here for a moment. Okay, so we got you.
Technical difficulty.
All right. Now, maybe? Okay. Good enough. I guess I'll just pull. Well, it's not even working like that, is it? Can you hear it?
People in the back deserve it. They're sitting where they sat down.
That's their choice.
Hold on, I'm gonna change the battery.
I'm blind.
When in
I'm
doubt.
supposed to wear glasses, but I don't.
Can you hear me now?
This is actually my glasses case in case you touch your faces.
I'm gonna text them to see if they can bring me a new bag. Case 54-year-old male. Smokes a lot, long-standing history, presents with shortness of breath, increased frequency of cough, change in baseline color of sputum over several days. On exam, he's in mild distress, respiratory rate 28, pulse ox 86. Patient has mild accessory muscle use, decreased breath sounds are observed bilaterally, and then faint expiratory wheezing. So, what are our treatment options? Which is what we're going to talk about today. So, anybody want to guess? Oxygen, good.
EPV.
Steroids, yes. What else? Pretty much same as asthma, some sort of albuterol, ipratropium, like Duaneb is what we prefer in these patients. All right. So there's our ABCs. So he's, he's got like 86% on room air, not uncommon in our COPD patients. So we like to keep them between like an 88 and a 92%. So we would, we'd certainly put some oxygen on this patient. And then we would consider all of our other treatments. So we'd start with our ABCDs, IVO2 monitor. We would start them on a Duaneb, get the steroids, oxygen on board. And then we would reassess and determine whether we need BiPAP or senior response to that therapy. All right. So COPD. This is, you have that airflow limitation, and they usually have like persistent symptoms. It's not reversible like in asthma, so they have some sort of chronic, usually some shortness of breath, or you might see a derangement on their like SpO2 that they chronically have. Most of the patients that present for an exacerbation present with shortness of breath. They have a chronic cough normally, but they have increased sputum production. So that's a good, important question we ask them. And then we want to look for, do they have risk factors like they're smokers? Most of these patients that have been diagnosed, we can ask them what their category is for how severe their COPD is. And maybe, we still use that like gold criteria for these. So it is the third leading cause of death in the U.S. So it is very common. We typically associate it with smokers, but we see it in a lot of patients that don't smoke as well. So it's not a slam dunk. We also, there are rare disorders like alpha antitrypsin deficiency. You can see it in certain populations that work with a lot of, dust or smoke exposure or machinery. Those patients that work, like shipbuilders and other things you see on questions, they may be associated with it. But the issue is, it leads to chronic hypoxia, it can lead to right heart failure, you get distended atrium, arrhythmias. So we have a lot of, we have multiple kind of pathologies going on or pathophysiology with these patients that we're concerned about when they present. So here's our classification of severity. So this is if they're diagnosed and they know their classification. We'll ask them if they know what their FEV1 is. Some patients may or may not. In the military, we can look it up in Genesis and kind of see what their category is if we're concerned for it. Sometimes it's helpful in the emergency department to know this, especially for those severe cases, but still we treat the patient, not their number, their classification of severity. And then here's our like classic symptoms. We get that chronic progressive shortness of breath, cough, and then for the exacerbation, I'll have sputum production. All right, hang on one second. Okay, so like I was saying, really the most common thing we're going to see is a shortness of breath and a cough. What we like to know is whether they have any increased sputum production or purulence or change in color of that sputum. On physical exam, you'll have that tachypnea, accessory muscle use, might have those pursed lips. And really that lower airway obstruction causes other symptoms like wheezing. The issue with these is they aren't able to expire like they normally can, like if you have healthy lungs. So that's usually what you see as a prolongation of that expiratory time. And then, we still use, we still teach like the pink puffer, blue bloater. The pink puffers, I think a lot less common now. Most of them are really just that chronic bronchitis versus that emphysema, but it is still a consideration. And some of them will have possibly different lab values on here, and we'll talk about those. Not as helpful, but you also may see like some hemoptysis in these patients. The reason that the patients are skinny is because they just have poor dietary intake, and they have the increase in their respirations into tachypnea, so it increases their caloric expenditure, and that's how we get that pink puffer. Not really super useful in clinical practice. Most of them are that chronic bronchitis type picture. Early stages of COPD, our VBG may have like a mild to moderate hypoxemia, no hypercapnia. Then in later stages, you get more severe hypoxemia. They start to get that elevated CO2 in there. And then they get worsening oxygenation during their acute exacerbations, or if they're climbing stairs or when they're sleeping. Signs of severe COPD, so you get that secondary polythysemia, so they may have that facial vascular engorgement. And really, it's the body's response, so you're not getting, the body's saying you're not getting enough oxygen to your tissues, so then it goes back to your kidneys, produce EPO, and it tells the bone marrow to create more blood cells, so that's why we see that polycythemia in these patients. Another difference that's in, well, let me see if we cover the next slides. Maybe not. Another difference we see, so in healthy lungs, our respiratory drive is like our PCO2 or PaCO2 level in our blood kind of regulates our brain to say we need to breathe more, we need to breathe less. In a COPD patient, that's altered, so it's based on their oxygen levels in their blood, so their PaO2. And this is important when we give oxygen to these patients, and why we typically keep them between 88 and 92%, because if we increase it, they're going to lose their respiratory drive. So it's kind of opposite of what a normal healthy lung does. So those are important considerations when we're treating them. We don't want to bring their SpO2 up to 100% in these patients. So because the right heart is supplying the blood to the pulmonary artery, we tend to see signs of right heart failure in these patients. This is why it can be difficult when we're diagnosing a COPD versus a CHF exacerbation, because they may actually present with both, with a picture of both. So that's why BMP can be a little bit helpful on there. We don't really get spirometry, like I said in the last lecture. This is more of an outpatient thing, because we want to know what their normal is at baseline, not when they're presenting with an exacerbation. So they're usually going to have some pathology in the ER. That's why they presented. So it's a lot more difficult for us to do an accurate spirometry on these patients. But if you do, you can, this is what you would see, especially if you're reading a note from like the Pulm Clinic when they were there. Chest X-ray. So if you guys remember, like the emphysema patients with increased, AP diameter, they have those flattened diaphragms, increased lucency. That's like your classic emphysema picture. Chronic bronchitis doesn't usually have a classic picture to it. You may be able to pick up a bleb on there. Usually that's more on a CT scan. And then here's our classic emphysema type picture. So you have those like flattened diaphragms, that increased diameter. And how do we diagnose this? So like I said, it's difficult to distinguish it from heart failure because they might have both. Our BMP can be helpful if it's normal. It doesn't rule out the heart failure, but it's a good indication that it's likely not heart failure. We do get an EKG on these patients because a lot of times they will have an arrhythmia. Sometimes I say they will have an arrhythmia associated with it, and that's usually like a right heart failure pattern or right ventricular strain. If we remember, like our MAT, might have different P wave morphology on there, and you might notice that like peak P waves and things like that on these. And then our treatment. So like we talked about at the beginning, oxygen. We want to give some sort of albuterol, ipratropium, Duodeneb combination for these patients. And then we do the steroids. The one thing we add for these patients is antibiotics. So most of them have like a polymicrobial bacteria that's causing this exacerbation. So these ones all get antibiotics when we're taking care of them. And then, you know, we want to look at like their sputum production or mucus secretion. We like to counsel them smoking cessation. Hopefully they quit smoking, and then we can do a pulmonary rehab as well, where they work with them to help mobilize those secretions, and they have a lot of different tools out there. Some they have like little percussion devices and other interventions we can utilize. All right, so long-term oxygen therapy reduces COPD mortality. It's probably one of the few things it does, and our goal is we want to get that PO2 over 60. Which is usually around 90%. So we like to keep it in that 88 to 92% range. Criteria for long-term therapy, they've got hypoxemia, so that PO2 is 55 or less, their SpO2 is 88. And we like to keep it somewhere close to that normal range. So an important question for COPD patients, do you use any at-home oxygen is always an important question. Then you want to know how many liters they're using as well. Same with like our heart failure patients may present similarly. And we ask them those questions. So we don't recommend long-term steroid therapy. It is something like the pulmonologist will use in certain cases, but it's not recommended by the guidelines for every COPD patient. They may have like an inhaled steroid instead of like a chronic systemic steroid. And then sometimes they'll be prescribed azithromycin to take on a chronic basis, but usually not. A lot of these patients will have, they'll be prescribed it if they have any changes, like they'll be managed by the pulmonologist if they have any changes in their sputum production, increased sputum production, or signs of like an acute exacerbation. A lot of them will have prophylactic antibiotics already. So it's important to ask them, have you been taking antibiotics? Some of them will even have steroids to use during these exacerbations beforehand if they have frequent chronic exacerbations. And then, some of the things we can do is increase that fluid intake, get them some sort of humidifier for their room to help mobilize those secretions. And then we don't, really everything else listed on there doesn't do anything. So if you look at studies for like, even when we get prescribed it for upper respiratory infections, I think almost, maybe not antihistamines, every other one of those like, doesn't work any better than a placebo, but it does. Patients don't like to hear that here's nothing, get out. So that's why we usually prescribe. But most of them don't work. And then smoking cessation is going to be our biggest intervention, and it reduces the rate of lung decline, function, and mortality from respiratory causes. So it's important that we start them on some sort of smoking cessation program if they're continue to smoke. And that's something on the outpatient side that you guys might manage. In the Army, when you go to like a battalion PA, you're probably not going to have any COPD patients, but I know I think Air Force works at family practice clinics that will treat elderly and kids. I don't know what the Navy does, but maybe they do too. All right, so here's what we're concerned about is an acute exacerbation of COPD when they come to the ER. And usually they have that cough and shortness of breath chronically, and if they have any worsening in it, so a lot of them will have an at-home pulse oximeter as well that they'll be measuring. But what we're looking for is any sort of increased sputum production, change in sputum color, and then did they have any recent infection or irritant that caused this? Usually they'll have, during flu season we see it a lot, they'll have some sort of respiratory infection or the cold that triggers this. And we want to look at other ones, like are they taking a beta blocker, did they start them on a new medication? Sometimes cold weather can cause it, narcotics, sedatives, so we want to consider all those during our evaluation for the acute exacerbation. But it's, we have that expiratory airflow limitation, which we also see in asthmatics. And that's typically the cause of this ventilation perfusion mismatch in these patients. So we want to give them some oxygen to help reverse that, but we don't want to give them too much. Like usually a nasal cannula is appropriate, and like 2 liters, depending on what they're using at home before this. And then what we worry about is that hypoxemia. So we're, most of these patients, we're going to get that blood gas. on exam, we might see that's tachypnea, tachycardia. They might have hypertension. Sometimes you'll see cyanosis. Change in mental status is usually not a good sign. But everything in the end stage, because of that alveolar hypoventilation, it causes that increased CO2 retention, and it can lead to respiratory acidosis. So a lot of times they'll come in, they'll be, they're sitting in a tripod position or leaning forward to try to move air a little bit better. One thing I would recommend is not laying them down like we do in a lot of hospitals, so that's going to worsen their condition. You may see that pursed lip breathing. All right. So like I said at the beginning, get a good history on these patients. If they have an infection, they recently started beta blocker or another medication. Are they taking opioids? If they have a recent injury? Sometimes it could just be the weather change and the seasons. Or was there any trauma? And then acute exacerbation, increased shortness of breath. They have frequent cough and increased sputum production. And that kind of helps us narrow down, this sounds like an acute COPD exacerbation. We also want to know the history, like asthmatics. When was your last exacerbation? Have you been hospitalized for it? Have you ever had to be intubated? If we can find their FEV1, great. And then we want to know about home oxygen use and comorbidities in these patients. All right, so our exam, just like everybody else, ABCs, vital signs. We're looking for that accessory muscle use. We're looking for, how many words they're able to complete, or can they speak in full sentences? Do I have good air movement on my lung exam? Are they tripoding? These are all important exam considerations. And then their chest exam may have wheezes. You may hear diminished breath sounds in certain areas of the lungs. And then other things of like that right heart failure or strain, you might have S3 gallop. And then you could have hepatomegaly, edema. So if we can find a cause, great. That's what we're looking for in the history. What might have caused this? What, are there sputum changes? And then we want to look at like their blood gas. So we want to assess what is their PO2 level? Is it below 60? And if we can find a baseline as well. So a lot of these patients will have had previous exacerbations. We can kind of look at what their baseline is. And then, at the bedside, pulse ox can be helpful. Just rough estimating hypoxemia. So is it, 92? Is it, 86? That can help us kind of determine. Capnography, usually that's more if we're using some sort of breathing treatment like non-invasive ventilation. And then we want to make sure we get a blood gas on these patients, just looking for that oxygenation, ventilation. So what's their O2, what's their CO2, and then are they acidotic? And we kind of, stratify it into how severe this is going to be and their clinical course. But respiratory failure is going to be that low PO2, so under the normal limit. And then we want to evaluate for respiratory acidosis and hypercapnia. So do they have, what's their CO2 level? Is it above normal? What's their PO2? And then are they acidotic? So, less, normal 7.35, 7.45, is it below that? And then we can kind of stratify into category whether it's respiratory acidosis, whether they're compensated, whether it's a mixed picture. How are you guys at reading ABGs? Professionals? Good. All right. So assessment is sputum. We really ask them like the volume and is there any change in color. It's kind of difficult to determine. We don't get sputum cultures because it grows like mixed flora, and it's not helpful for their evaluation. So, there aren't like classic radiographic findings on there. What we're looking for is any other, like whether we think we might see a cardiomegaly or whether we might see a pneumonia accompanying their exacerbation or causing the exacerbation. Or if you're looking for ulterior diagnosis, so if you got that pulmonary hypertension or signs of heart failure on there. EKG if we're concerned for ischemia, which we get an EKG in most of these patients. Just to rule out any sort of ACS, but you may see some dysrhythmias on there or signs of right heart strain. Labs, we want to evaluate CBC, just looking for any like elevated white count or signs of infection. We can also look for that polycythemia as well. That can cue us to how chronic this might be. And we want to assess their electrolytes, get a BMP. These patients have a higher risk of PE, so sometimes we're going to do dimer and a CT angio of the chest. What becomes tricky is when they have frequent or recurrent exacerbations and we're scanning them too much. So we always need to consider that. And then we can do a point-of-care ultrasound as well, looking with thorax edema and things like that. But our goal of treatment, get them some oxygen, so correct the tissue oxygenation. We want to alleviate that bronchospasm with our beta agonist and our anticholinergic. And then we want to figure out if there's an underlying cause on there. Was there a recent, they recently had the flu? Did they have a pneumonia? We want to treat that. And then we want to get them steroids. So here's our oxygen. Our goal, we want to keep them right around normal, so right around that 60 to 70, which is roughly about 88-92% on their oxygen saturation. So we can use our nasal cannula, which is a two-prong there. We may increase oxygen level with like a simple face mask. And then we can also use other things like high-flow nasal cannulas and BiPAP as well if we're not getting the response that we're expecting. So here's our short-acting beta agonist. We usually give those, typically every 20 minutes for the first hour. And that's our do-and-ep combination for these. The issue with these patients, because they have a higher risk for arrhythmias because of the COPD, we want to make sure we're monitoring their cardiac function. Plus, the beta agonists are going to increase their heart rate as well, so we always want to keep them on a monitor when we're treating them with these. And then we have the anticholinergic, so ipratropium is going to be the most common one that we're using. We don't use long-acting anticholinergics during an acute exacerbation, but it might be something they're prescribed at home. They take on a daily basis. And then our steroids, so usually a 5 to 7 day course of systemic steroids. So, prednisone, usually 50 to 60 milligrams is considered high dose. And we give that 5 to 7 days. Because the steroid takes, about 6 hours for a response, it may or may not help us in our disposition decision because we don't like to keep patients for 6 hours in the ER, so we'll likely admit them before then. A lot of them will get admitted before those corticosteroids start to show an effect on them. We also want to know if they're diabetics, and we monitor their blood sugar levels, especially if they're in the hospital. And then antibiotics. So once again, most common pathogens like we just talked about, pneumonia, is what we're covering. None of the agents are better than another. It's important to look up what the current guidelines are and what your resistance patterns are. A lot of these patients are still taking like the zithromycin. More frequently now we're using like augmentin with them. And we may use a fluoroquinolone on these patients just because of their risk factors. Then our non-invasive ventilation. So if we don't see a response to our initial treatment or if they present in extremis, we may jump right to our non-invasive ventilation, or we may have to use that as an adjunct in our treatment. And they, it's usually tolerated well. We just worry about if there's altered mental status, whether they can tolerate it. And here's some of the disadvantages. So it's a little bit slower in correcting gas exchange. You have that risk of aspiration because they have a mask on. So if, let's say they vomit or something like that, it can be a concern. And then it's hard to get, deal with airway secretion. It's also hard to get a history if you have it on them as well. But if they're on non-invasive, we usually have to monitor them a lot more frequently. We want to measure their cardiac function as well. And then mechanical ventilation. So similarly to our asthma patients, if we're seeing any sort of, if the patient looks like they're tiring out, any sort of respiratory fatigue, or their acidosis is worsening, they change in mental status, then we're looking at intubating these patients. And really it just lets their muscles relax as we restore that adequate gas exchange. However, invasive ventilation, we can cause a pneumonia, barotrauma, a pneumothorax, and it can be hard to wean them off the ventilator, so we try to avoid that if we can. Here are some rough indications. for if we need to ventilate that patient. So hopefully it makes sense. You know, they're altered, they can't tolerate non-invasive, any sort of, I mean, I would think it's common sense, like cardiac arrest, yeah, we probably need to take their airway. And then respiratory failure, really the persistent hypoxemia, we can't improve it with our non-invasive, got aspiration risk, hypotensive, you know, our septic type patients are the ones that are going to receive that may be considered for intubation. And then here's kind of a recap of everything we just talked about. So we want to assess that severity, usually with a blood gas if we can. And then we want to look at what that PO2 level is and then tailor our therapy. But everybody gets oxygen, they get, you know, the bronchodilator, anticholinergic, we get steroids on board, we get antibiotics. And then we reassess and consider whether we need non-invasive ventilation, do I see improvement? And then our ancillary testing hopefully starts to come in then and give us a better picture of what we're looking at. And then we want to think about their comorbidities. So what's our disposition? You know, patients with acute exacerbation have a higher risk of relapse. They, you know, we can use like stratification on activity limitations, you know, what's their initial respiratory rate. We usually just, for most of these patients, if we see signs of improvement, we do what we call a walk of life when we check their SpO2 as they're ambulating and performing their activities of daily living. And if they can tolerate it without becoming hypoxemic, then we can hopefully disposition them home. Anybody that doesn't improve with therapy, significant comorbidities, we want to consider admission. Or once again, they don't have that social support system, we're going to consider that as well. You are going to see a lot of relapse or bounce backs from these patients. So it's important if we're discharging them, we get a follow-up appointment for some sort of follow-on care for them. And then here's some indications for hospital admission. So like I said, failure to respond, significant comorbidities, any arrhythmias, chronic frequent exacerbations, the elderly, they live at home by themselves, they're not compliant with their medications, we want to consider admission. All right, if you're discharging them, if they're using at-home oxygen, we want to make sure they have an adequate supply of it. They need to have bronchodilator therapy, so we're going to make sure they have the appropriate number of inhalers, they know how to use them. Do they have nebulizer therapy at home? And then we send them home with steroids. Then we want to get a follow-up appointment either with a PCM or pulmonology is preferable. Like I said, we do that walk of life before we discharge them. So we ambulate them and we check for any desaturation, increase in symptoms. All right, check on learning. 54-year-old, long-time history of smoking, presents with a shortness of breath, increased frequency of cough, change in the baseline color sputum over several days. On exam, patients in mild distress, respiratory rate 28, SpO2 86. Patient has mild accessory muscle use, decreased breath sounds observed bilaterally with faint expiratory wheezing. What is the differential?
Cap, bacterial infection.
COPD. Since we're talking about it.
COPD.
Well, we want to consider all those, you know, is this a heart failure picture because we know they're at a higher risk. They also are at a higher risk for PE. Is this an infection like a pneumonia? So it's a broad differential, and that's when we use our ancillary testing for these. Physical exam findings, likely you're going to have some sort of adventitious lung sounds on your exam. They'll be tachypnic, maybe tachycardic, hypoxic. And then we work them up. We get the chest x-ray, EKG, labs, and treat them with oxygen, arduinib, steroids, antibiotics, and then reassess whether they're coming in the hospital or going. All right, that's everything I pretty much just said. What questions y'all got? I know all you guys care about is Friday, right? Just shut up.